Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists. Well, listeners, welcome back to an interview episode, or an episode with an interview that I think is going to be one of my favorite topics that I've been talking about in a while. And I'm going to talk about it with one of my favorite people that you have all heard, and you've also said is your favorite, Dr. Pam Maragliano-Muniz. Welcome back to the podcast.
It's a pleasure to be back. Thank you for inviting me.
Always, always. I am really excited about this topic because, I should say, we're going to be talking about GBT, or guided biofilm therapy, and the use of AIRFLOW from EMS. And when did you first hear it? Because I have a story around when I first heard about it. When did you go, what is this? What is this?
So I heard about it, I guess, it must have been, now I know this is all a blur, so work with me here. I would say it was either late 2019 or early 2020. I remember hearing about it and I was like, oh, sounds good. Sounds expensive, but it sounds good. And I thought it was interesting, but for me, it took a pandemic to get me 100% on board. So I'm excited to share that story with you.
Oh, yeah. And I heard about it. So I actually used the handpiece one that attached to your unit, which had the water, your handpiece, your slow speed or whatever. And I was like, I love the idea that I'm not tearing up people's tissue, because I was a huge sodium bicarbonate fan for, I'd say, 90% of my career up until a few years ago. And I saw it at Europerio. And I got to try it because they had just introduced the new fancy AIRFLOW with the PAs on attached, all on that sexy little unit that looks like an espresso machine. And I was like, oh, this is nice. And it warms the water. But then everyone's like, yeah, you're just not going to have to, the goal is not to scale anymore. And I was like, okay, let me stop you there. I'm a hygienist. It's like crack for me. If I don't pop calculus off, am I really a hygienist? And man, I have changed that point of view completely. And you're a previous hygienist turned crazy great prosthodontist. So tell us what your experience was on this journey. And did you also have that same reaction that I did? I was like, come again, I'm not putting a scale. What? Just this?
Well, it's funny. Yeah. I mean, it almost seems a little bit too good to be true. And to be honest with you, it's actually true. So it's not too good to be true. It was one of those things that I'm really into long-term outcomes. And I know that it's very damaging to use prophy paste, especially on composite restorations, on lithium disilicate and different restorative materials. Obviously, we all know what prophy paste does to gold. If you haven't done the swirl on a gold restoration, we've all done that. And it was one of those things that I was trying to seek something better. And I saw the value of air polishing. And it was just one of those things getting, maybe my hygienist on board or whatever, but it was just one of those things that I wasn't really sure exactly how I was going to bring this in or when I was going to bring this in. But basically, here we are, office is closed. I get to sit back and think about the office and my life and my dog and all the things that we did. And it was one of those things where I was just like, I want to be better. I can be better. I'm going to be better. And I also felt that I spent some time researching more on the oral systemic health. And we know there's such a connection there. And I just thought, my gosh, telling patients to make sure they get annual physicals or, just sort of encouraging them to be healthy really wasn't enough. And I felt like we needed to do our part to try to break that link. And the only real reliable way to do it is by bringing in GBT. And I will say that I mean, this has been a practice changer. This has been, I mean, the whole practice is totally different. And this was something where I was just thinking, gosh, I want to be better. I want to do better for my patients. And the outcomes have been just astounding.
Yeah. And so I guess what we should talk about too is that what we're using the AIRFLOW Prophylaxis Master unit from EMS, and that is going to have your handpiece that has the erythritol, which is like air, water, and powder, all kind of going through this little handpiece. And what that's doing is attacking the biofilm, which is the cause of disease. And I think that's where, well, I should say, I was learning all of the little pieces, and we'll talk about the compass in a minute, but like I was learning all these pieces individually. You know, I was learning motivational interviewing, and I was so gung-ho on home care, and that being like the true way to prevent the disease that we are all, you know, talking about prevention. And then I was learning about erythritol, glycine at the time, because we didn't even have erythritol yet here in the US. And then I was like, oh my gosh, this is so great, because like I said, I've been using sodium bicarbonate for so long but I've been in perio. So you have like the dental materials, you know, frame of mind. And I'm over here like root surfaces, like, yikes, I can't do much here, but I'm also haunted with chlorhexidine. So like, what's a girl to do? And, you know, and then I'm scaling these like sensitive little root surfaces or implants. Like I was dealing with implants all the time. And so now with the AIRFLOW Prophylaxis Master, it's almost like flipping the script a little bit on our appointments, right? So maybe you were taught to do some brushing instructions, some home care stuff, and then scale, polish, floss, fluoride, right? Like, wasn't that our script for so long? And now we are flipping it, and we're using that erythritol to really attack what creates disease, and then using the Piezon technology, which is the ultrasonic, to disrupt any of the harder deposits that a patient might have at that moment. But our ultimate goal, is to motivate and assess properly so that we prevent the need to knock off that hard deposit.
That's so true. And I'm excited to kind of go through the whole system, because I will say that, yes, it flipped the script on everything I knew. And I was like, wait a minute, but I've been a hygienist since 1998 and it's been good enough. And you know what? It hasn't been good enough, because I think, for starters, which is kind of blows my mind, biofilm research dates back to 1979.
Isn't that crazy?
It blows my mind that here we are talking about this. And I mean, I've been at it for, I guess, a little over a year, really intentionally. But I mean, that's decades that have gone by, and all of a sudden now it's getting attention. And I also think that, you know, you mentioned before, what's a girl to do? What happens when you have patients that have bone loss, attachment loss, root surfaces? Think about the fact that there's so much more surface area to clean. And do you get more time to do it?
No, of course definitely not.
So we have to, if we really want to break this link, this oral systemic link, and we really want to prioritize the patient's overall health and us doing our part, we need something that's efficient. We need something that works, and something, obviously, something that is not going to ruin our appointments. Something that we can do without, while prioritizing ergonomics. So there's so many reasons that this is such a great system, and I'm really excited to kind of go through it, and I'm interested to see if your experiences are the same as mine.
Yeah, I'm really excited because, like I said, I've been doing. I started with glycine when it was here with like the hand pieces, and then I got my AIRFLOW unit just before COVID. Ugh. And then, but now I'm back using it because I have all the aerosol management things that I could ever imagine and want and desire. I've tested the airflow of my suction unit, and I feel very confident that I am doing a great job at managing my aerosol production with patients. And I don't know who was more excited that I got back to this, if it was me or the patients. Maybe a little combo of it. but it has changed everything.
It really has. And it was interesting because bringing in something like this, I had a bunch of changes happen after we reopened from the pandemic. So I replaced my entire clinical team.
You did, yes.
I did. And so here I have a practice that at this point was 30 something years old. I've got patients that have been part of the practice for a very long time. Now they're going to see a new person. Thankfully, they were incognito. They probably didn't even know it was a new person. But, I had a new hygienist and I had all of this new technology. We had obviously safety equipment, but we had new technology for them to experience. And so you can't help as a practice owner to think, am I throwing too many new things at these people? Are they going to think I'm crazy? Are they going to head for the hills because all of a sudden everything is so different? And I can tell you, it was not like that at all. I can't tell you how engaged the patients are, so much more so than ever, how much they love the technology, or even if they're kind of not sure about the technology, once I explain the intended benefits of the technology, they're just like, oh, okay, yeah, all right, I want that next time. And it's obviously something we do on every single patient. It's just part of our normal workflow. But this is something that patients have noticed a difference. They appreciate the difference, and they appreciate that we're prioritizing their overall well-being.
Yeah. So let's talk about what guided biofilm therapy is. And you'll hear us say GBT. We are using this very specific system from EMS, but really the compass, the journey, this routine that we're kind of following is what we are doing to manage that whole patient, right? So let's talk about GBT. So the first part is the assessment and infection control is what it says. So tell us what your office is doing for that first step.
So obviously unless I know you love infection control. I do too. Maybe like a rank down from you. But I think we're doing what everybody else is and should be doing. So obviously PPE, high speed suction for hygienists, face shields, etc. Do you want to talk about some of our favorite infection control products, or do you want to just kind of stick to GBT?
We could stick to GBT because I think the part about, because they could also go back to our other episode that we did at the end of last year where we talked about a lot of our stuff.
That's right. Yes.
Because I think the assessment part is so critical.
It is. And I guess this brings me to another little pearl that happened during the pandemic. This was something I brought in with the intention of trying to minimize extra pairs of hands needed in the operatory, or, the hygienist doing those class 5 movements between the patient and the computer or a pen and a piece of paper. Mm-hmm. And we brought in the Florida probe, VoiceWorks specifically.
I have been using VoiceWorks for years.
Honestly, I have known about it for years, and I had no idea what VoiceWorks would do for my practice. And also, it's such a beautiful component of GBT because it makes, when we get a few steps down in this compass, it makes the motivation and patient understanding what's going on so easy, and the patient is part of it. So we all probe. We've all been probing forever. But if you probe and you go through the whole appointment, and then later, after it's all said and done, you're trying to explain what pocket depths are and, areas that might be more involved than others, you've kind of already lost them. Patients are in the moment. Yeah. So when they can hear their probing depths and they can feel that maybe something's a little more tender, and all of a sudden Sarah's calling out a 6 or a 5 or, whatever, we know that the patient kind of knows that this number correlates to, something that's not feeling so hot in their mouth. And all of a sudden, when it comes time to explain what was done or what we found, the patient's already engaged. They're into it right now. And any recommendations that are made from a periodontal standpoint, patients are just on board because they get it.
Yeah, and I really do like the idea of like, okay, so I'm doing this probing, I'm calling it out, I'm faster, so I'm doing it because I know like how it feels when you're like, oh my God, I gotta do this. And it takes so much time and they're multiple sixes, let's say. But it also, it allows me to be faster, but then it's like clicking in my mind, maybe I need to do some subgingival airflow or perio flow. And we'll talk about that a little bit more, but that assessment stage for me, it's like triggering. And I love VoiceWorks because it has like caution, danger.
Danger.
if there's like a 5 or a 6 or 7, like it'll give you a little thing and the patient will hear caution. Like it always makes me giggle, but I can
but you can turn it off if you need to.
You can. I always left mine off. And I love that I can do bleeding as well, because if we're following the new AAP classifications, the grading and the staging, like we really need to get our bleeding points and get a percentage of those bleeding points. And then we can truly see each time the patient comes back and we're using airflow on them and we're doing guided biofilm therapy, we can truly track the bleeding points, which is what we are concerned about, right?
Absolutely. And that's another thing. I mean, gosh, I know this isn't about VoiceWorks, but VoiceWorks is pretty awesome. The software is so useful. So the software has all of that data that you need to properly stage and grade. They have a perio risk assessment form. They've got patient handouts. So it's not just voice activated probing. There's so much more to that software. It really allows you to kind of create your whole soft tissue management, documentation, recommendations, etc., all right there on the platform, which is kind of awesome.
It is quite awesome. So we're doing this assessment, which I think we all do, but it's just kind of really gearing you up for what the rest of GBT will look like. Because the next stage, which is one of my favorite stages, is disclosing.
Yes, it is. And I always explain to people okay, let me tell you about my first job as a dental hygienist.
Oh, yes.
I was really, really lucky. I worked in a practice where we were given 75 minutes for a standard prophy.
Wow.
Now, as your first position, I felt like I had no time. It was a miracle that I had 75 minutes because if I had 60, I would have been in big trouble. And I remember talking to the hygienist that was there for about, I don't know, she was there for like 12 or 13 years. And I said to her, gosh, how do you stay on time? Because, oh my gosh, I was talking patients out of x-rays. Like I had no time for anything. And so I asked her how she stayed on time. And she said, I don't waste my time on areas that don't need it. And initially, and it's so funny that all these years later, I still think about that. And when I heard that, I was like, oh, you mean you don't scale every surface? Well, I am going to scale every surface. And so I kind of ignored that recommendation because I need to scale every surface. What if the patient thinks I skipped something? What if I did skip something? And that was something I was not willing to do. And now here we are, all these years later, disclosing, allowing us to identify where there's biofilm, where there's not biofilm, but there's always biofilm. And now we know we have a roadmap. We don't have to spend time on areas that don't need it. So this chick from decades ago was absolutely right.
So now that I am disclosing again, so I went from 2005, the moment I graduated, I probably burned my bottle of disclosing solution because I tied it to grading, right? I didn't tie it to patient's health. I'm like, what? I was missing a huge piece of the puzzle. And now that I'm back, well, granted, back when I used it was just one color. And now I'm using the tri-plaque gel that gives me the 3 colors. And the conversation has changed. Oh my gosh. Like I would like to think that I'm a pretty decent storyteller. And I thought I was giving like some vivid like story about the biofilm maturing and like what was actually happening in the process. And like all I needed to do was turn their teeth a color, and they were like, "Oh, I got it." Like, I'm like, "Oh my gosh, I missed so many years without that disclosing solution."
It's so true. And it's amazing that patients that you've had for years and they've been your patient and you know them and they're sort of checked out and you go through the motions, all of a sudden you bring in something like TriPlaque ID from GC America, and all of a sudden they're like, wait a minute, what color? And now that not only are they engaged right now, they can't wait to see what they look like at their next recall. So now they're asking for it. They need to see how they did over the past few months.
Exactly. And you know what's so funny is that there's this one patient that I always think about, and he was such a stoic man. And I did it, and he had a lot of the deep purple, which I knew. I could have told you. I saw it, right? Like, but he saw it then. And he comes back for his recall, and he's like sitting in the chair. You know how sometimes they're grumpy and they just kind of like fall into the chair. And he was like, I hope hell I'm not going to see any of that purple again. And I was like, he's interested. I finally have him interested. And I'm like, oh, well, tell me more about, and then I used my motivational interviewing skills that I've been really working on to get into that next step, which is motivating the patient. But it all started with that disclosing the patient and showing him what I was seeing and the concerns that I had based on the colors I was seeing from this gel. It was like, changed everything.
I would also argue that it not only helps to motivate the patient, but it also helps to educate us.
Girl, yes. What a good point.
You don't always see biofilm. You see materia alba, you see plaque, you see things that are, kind of disgusting depending on how well you see. But for the most part, when we're talking about biofilm, you don't really know the characteristics of that biofilm until you disclose the patient. So obviously, if if what you have in your practice is a single color disclosing agent, don't worry about it. That's cool that you have it. Obviously, something like TriPlaque ID is going to give us even more diagnostic information, but it's really important for us to identify where there is plaque. I mean, and biofilm, and we always say, well, if there's bleeding, it's probably there, or they must be missing it, or they must be doing something. Well, it's pretty amazing that if we disclosed after we did our traditional scaling and rubber cup polishing, I bet you we're missing things too.
Oh, yes. And, and I can talk more about this when we get to the actual AIRFLOW procedure, part of GPT. But what I have been seeing a lot lately, and it's daily. Anytime I'm in clinic, I see this at least one time with a patient. But if I see that thick purple biofilm, when I'm using the AIRFLOW and I'm starting to kind of peel the layers back and I'm truly staying on that tooth for the, with the correct angle and everything, I'm going through the colors. I'm seeing the light blue. I'm seeing the pink. So I'm seeing all, because just upon looking at it, and if I had polished it away, I wouldn't have had the opportunity to see how complex that biofilm was. And when the first time I saw that, I was like, oh, well, that's interesting. Let's talk about pH control. Like, my conversation was not about pH and saliva and stuff at first, but it turned to that because I just kept finding that light blue bacteria in their mouth.
So shout out to hygienists wearing loupes. So let's just throw that out there.
And a light. Oh, yes.
Yeah, loupes and a light. I don't think anybody would really be able to see what you're describing if you didn't have loupes and a light. But I think also it's probably worth mentioning, I know we've talked about this before, but just in case, you're tuning in for the first time or you just need a little reminder, TriPlaque ID is interesting. So you disclose the patient, there's the potential for 3 different colors to arise on the patient's teeth. And that is indicative of different characteristics of biofilm. So there's hot pink biofilm, which is new. So I don't know, if you disclosed me right now, I haven't brushed my teeth since the morning. There'd be some hot pink in there. And thankfully, we're not doing that. But if we disclose the patient and there was that dark purple biofilm like you were describing, that's biofilm that has been allowed to mature and sit there and proliferate for over 48 hours or longer. There's also the potential for this turquoise blue biofilm to arise. And that's a cytogenic biofilm. That is biofilm that is sitting in a pH of 4.5 or less. That's pathogenic biofilm, karyogenic biofilm. And so it's interesting for us to be able to identify not only just the presence of biofilm, but what does this biofilm mean to this particular patient and how are we going to make them healthy?
Yeah. And it really kind of then leads us into the third part of GBT, which is 8 steps. I think I said the compass, but there's 8 parts to GBT, and that is motivating the patient. And it just really helps to guide the conversation. At least it does for me in my clinical care. It's like if I see more acidity or more of the acidic bacteria, then I am going to be talking pH control and, their nutrition. And it's always, I'm not going to say it, LaCroix. It's always that. I swear to God, they're using LaCroix or drinking LaCroix every dang day. So that's one of my conversations, or I talk about little treats that they can chew on after the fact, or I get into home care and we talk about what they like to use, to clean between their teeth and the type of toothbrush that they like and what's their lifestyle like. And I love that EMS puts that at the front of the appointment, at the top of this. Like we're not even putting it outside of oral cancer screening in our assessment stage, I'm like barely doing anything so far in their mouth with an instrument. And I love that.
I think this step 3 is the most profound placement for this step in the appointment. So if you say, oh, dang it, I don't have the AIRFLOW Prophylaxis Master, I can't practice GBT. You can practice the steps of GBT. Yes, you might not have the AIRFLOW Prophylaxis Master. Put it on your Christmas list. Hopefully you'll get it. But you can do this. Now, just like we talked about with VoiceWorks, now the patient's disclosed. You will not, from a periodontal standpoint, have the patient more engaged in their health than you will at any other time during the appointment than you have right now. So now is the time to educate, to make your periodontal recommendations. You've already done all of your charting. You know if they need scaling and root planing. You know if you're going to use any sort of adjunct therapy. You kind of have an idea of what's going on here. Have that conversation now. You want them going home with a water pick or an electric toothbrush or whatever. Now is the time for all of the dental hygiene recommendations. Because if you wait until the end of the appointment, patient's forgotten. And now you have to kind of remind them that they had bleeding when you were probing. Remember an hour ago when I was probing and you were like, oh yeah, that part hurts. And I was like, oh, that's a 5. And that means that there's a little bone. No. You don't have to waste your time with any of that. Now is the time to make all of your periodontal recommendations. The patient is completely engaged. And this is when they say yes and they commit to their periodontal therapy. It is the most amazing thing that I've seen. And this right here is responsible, probably coupled with having Amber and Sarah in the office. This is responsible for the success of our periodontal department.
I mean, I've always been a big home care. I will have to give full credit to the periodontist I worked for. I had a plethora of products. I mean, she really put emphasis on it. But me as the hygienist, I got in there and got the things done. And then I sat the patient up and I talked home care. And man, flipping the script, it's the way it should be done. Really. And it's kind of like, why did it take me 15 years? But okay, I'm here.
Yes. Thank you, EMS, for making us do what we should have been doing forever.
Right.
But this is the most, and honestly, this is where we get the commitment from the patient for them to even take care of their own oral health. So yeah, I mean, you're hearing this today, try this tomorrow and you'll be amazed. It really is incredible.
It really is. And so now we just talked about step 3. So assessment, disclosing, motivating the patient. 2, 3, which kind of is like this little chunk, right? Like that's the chunk of like if I had to put this into threes, I'd say like that's a third of the compass. And then we have 4 and 5, which kind of go together because it's our AIRFLOW or using the AIRFLOW Max new handpiece that they have, or PerioFlow. And just to quickly, like, I guess, preface this, that I think I've only used PerioFlow a handful of times because that is the tip that goes more subgingival. I've been very lucky to just be dealing with some gingivitis patients, some early periodontal disease, but nothing super deep like I was back when I was working in perio. So I haven't used that. So there's 8 steps in this, but you might skip a few. You might only do 5. Is that what you're finding too?
It depends on what the patient needs.
Right.
Definitely, yes. We do sort of lump this section of the appointment, AIRFLOW, PerioFlow, and even Piezon, kind of, if like you're saying, if you're going to kind of chunk the appointments together. This is periodontal therapy. This is the part that I love because I don't like, and this is not for everybody, but I like to just focus on what I'm doing. I can't tell you about my life and my day and my dog and my traveling while I'm prepping a crown. And so I like to focus on what I'm doing. We now have the high-speed suction on. Now, like that is like during periodontal therapy is not the time to try to get a patient to understand. You've motivated them. They've accepted treatment. Now the patient can just relax. You can turn your suction on. You can just focus on what you need to do. And now it's time to polish. Now, this is also another flip of the script.
Exactly.
Because we're polishing before hard debris removal, before calculus removal. So if you were an assess scale polish person, well, we've now assessed, we've motivated, now we're polishing, and then we'll get to hard deposits later.
And our polish is now geared towards biofilm management. Like it's not just about the staining and the cosmetic side of it, right? Like now we are really getting after the disease or what causes the disease. So this is such a huge part of the appointment. And I got to tell you, like if I could just AIRFLOW people every day, all day, it's like the most soothing thing to my soul.
It's amazing. So fun. Well, honestly, I think we should be AIRFLOWing patients before we place a restoration.
Oh,
think about how patients come back, and now we have to place a class 2 composite on somebody who doesn't really floss that. Obviously, if their oral hygiene was perfect, and we know there's plenty of reasons why somebody gets caries and they would need a restoration, but chances are there's biofilm chilling between those 2 teeth, and we're now placing our restoration in sort of a cesspool. And so I think that, there's so many uses for AIRFLOW Prophylaxis Master in the practice, not just in hygiene, but also in restorative. But you mentioned the erythritol powder. I think that one of the things that it still haunts me to this day, I shot this video on dentistryIQ.com with Brian Novi. I don't know, it might even be a year ago at this point. I approached Brian because I was upset that I had a patient who was using lozenges to stop using chewing tobacco. And his teeth were falling apart.
Oh, yeah.
And the patient's like, I don't understand, what I'm using is sugar-free. What we might not all know as dental professionals is that just because there are sugar substitutes used in products so that they can claim sugar-free, sugar-free generally means that us as humans cannot metabolize that as sugar. However, items that are sugar-free, even though they don't make us gain weight, strep mutans and other bacteria can metabolize them the same way they do sucrose. And so it's very important when you're making recommendations that you look at the ingredient list, make sure if it's a sugar-free product that it's not a sugar that bacteria can metabolize. And erythritol is one of those that bacteria cannot metabolize. So erythritol is gentle, It's got a low RDA. It's safe, and it's safe on every tooth surface, cementum, dentin, enamel, composite, glass ionomer. I mean, you name it, you can use it on any surface. You can use it on the patient's tongue. If they've got one of those coated tongues, you can blast that out.
Yeah.
It's incredible. And it has a natural antimicrobial benefit. So it's really one of those powders that it's not just great for biofilm, breaking up biofilm and removal of biofilm and stain and et cetera. It's actually providing a therapeutic benefit. So it's really one of those that you're getting multiple benefits out of one product.
And, so there's a few things that, like, if this is your first time, and even I have these conversations with my patients because I try to prep them. I don't say we, I try to speak to just myself because not everybody has the airflow in the offices that I practice at. It's just my little sweet baby. And so I'm like, we're replacing that like minty kind of fresh, like gritty paste at the very end. And we're flipping it, and we're about to use something that's going to be so pleasant and so gentle, but it is going to remove all of that sticky plaque that we just saw on your teeth, that whatever that is, the conversation I have. And when I'm done, because I have them hold the mirror while I'm going through home care instructions with the motivation, and then I have them hold the mirror afterwards, and oh my gosh, they're like, I can't believe you were even doing anything. I just thought it was water. It almost had like a slightly sweet taste to it. And within this hand piece on the AIRFLOW Prophylaxis Master, it's heating the water. Like, if anyone has ever used any kind of like sodium bicarbonate air spray situation, you will know very quickly if your patient has sensitivity, right? They are going to tell you very quickly, give you a slight heart attack when they jump. Like, it's just not pleasant. And also with like the sodium bicarbonate, you have to be gentle. You have to be careful. You have to worry about which direction you're going. And if you're protecting the tongue and protecting the lips, and the tricks that I had learned with gauze and Vaseline for the longest time, trying to protect my patients, like tissue and lips and everything, I don't even have to worry about that. These patients are like, wow, this is like so comfortable. And I almost have to tell them, like, I am doing something. You see the before and we're going to see the after, because I think if I didn't have that conversation with them, they would probably call the front office and be like, that girl just like rinsed my mouth out. It's so comfortable.
It's so true. We describe it as a car wash for your mouth.
Yes.
And patients love that. I usually walk in for my hygiene or my periodic exam, and patients like, oh, I love the car wash for my mouth. I'm like, all right, cool. But it's funny that you mentioned that the two, and we've been using this on every single patient, every single appointment for over a year now. The two people who gave me negative feedback basically felt that nothing was being done. They're used to having their head roll around as you're scaling and being crazy, and they like to be worked over and they like to be beaten up. And so yes, they were like, not sure what this was all about. However, once you explain the health benefits and the oral benefits, they were like, all right, well, I trust you, and I like what you're saying, and there's evidence behind it. So it's not like we're just making this up.
Right.
And now, now they look forward to it.
Yeah, exactly. They really do look forward to it. And it really is so nice to know that I am doing something that's therapeutic and truly removing and disrupting that biofilm. I can see it. It's like pressure. I think it's like pressure washing the side of a house, right? Like, I can actually see the change. And then I will even sometimes start to see like a little bleeding in areas that I didn't see a lot of biofilm. And I'm like, okay, like, let me take note of that, because that didn't pop up into my head when I did the disclosing. Let me make sure that this isn't happening anywhere else in their mouth. And I mean, it's a treat for both of us. I enjoy doing it and the patients are enjoying it. And so with the AIRFLOW, though, the handpiece, it is a little bit different. It's a different technique. That was probably my only struggle, is that I went from my 15 years of sodium bicarbonate and having to readjust and actually angled slightly towards the tissue. And that felt so wrong, so wrong. And I was easily going back, and I was then spraying me and everybody. So I got it together. I got my technique together. And then I occasionally break out that PerioFlow, which is meant to take that erythritol powder down into that sulcus, into that pocket that we, probed and said, okay, this is a 6 millimeter pocket. It's bleeding. But what have we ever done? Like before, we were just doing lavage, right? Like we were using the ultrasonic, but you're not really doing anything for the tissue, right? Am on the right track here?
Yeah.
Like you weren't really ever doing anything for the tissue. And then now with this burst of that erythritol powder, it's coming out both sides of that tip that is inserted into that sulcus, and it's getting and cleaning the tooth, the hard tissue, and also the soft tissue.
Absolutely.
And like, if that doesn't blow your mind, I mean...
And while the patient's comfortable the whole time.
Exactly.
It's not like, I would say there's very few patients that need topical while they're using this. The other thing that I know initially back in the day, people were concerned about were the aerosol production. But I think once you're using high-speed suction, there's lots of different ones out there. We have a few in the office, and we kind of tailor it based on what the patient is most comfortable with. But Sarah and Amber are wearing face shields the entire time, and they're not covered in splatter either. So it's pretty amazing that these quote unquote aerosols that you could be generating are just all under control. And not only that, it's been described a certain way that once the erythritol powder hits the tooth, and if it were to bounce back, anything that could be splattered back is considered inactive. I don't really understand exactly how that works, but if I was going to choose between some splatter from my handpiece versus any sort of splatter from the AIRFLOW Prophylaxis Master, I would take the AIRFLOW any day.
Well, and there was actually that great study that came out. If you go back and listen to the podcast with Spring Hatfield that we did, where they studied the spatter and the spray and the aerosols, and it was actually mostly dental unit waterline pathogens.
Hello.
It wasn't even anything from the patient's oral cavity. And I mean, that was with and without HVE. I have lots of questions about even their dental unit water lines that they were shocking and testing and doing the things. But nonetheless, that was the majority of the pathogens. And they were looking for COVID, and they were not able to, which is very hard to do with viruses, but still, like, they weren't able to find many other pathogens outside of dental unit waterline pathogens. And trust me, you can clean the water from the in the AIRFLOW Prophylaxis Master, so don't you worry.
Absolutely.
So, no, and I think you're right. Like, I would definitely group this compass, this 4, 5, and 6 together in its like own little unit, right? So we've gotten the AIRFLOW, where we're truly getting after the biofilm thing that causes disease. We can go subgingival with PerioFlow and really treat to the base of that pocket in a lot of cases. And then we have the Piezon, which is the ultrasonic unit. And I have such a love for Piezon technology. And I did not grow up on that. I definitely had magnetostrictive growing up, and it was a hard adjustment because I didn't have the best one when I first was introduced to it. But now I'm like, live and breathe by it.
Absolutely. I mean, one thing that I think we've all been lacking when we're using our magnetostrictive ultrasonics is that ability to feel for calculus. And so now you use something like Piezon. The tips are so thin. They're thinner than some perio probes. And you can go and you basically just sort of feel around the tooth, and you walk it like a probe, and you feel for any hard deposits. And if you do, there's a cordless foot pedal when you're using the AIRFLOW or the Piezon, and then you turn it on and it will blast any calculus away. And you'll be able to see, and the other thing that's cool, like not to go back a step, but as you're using your airflow, it actually displaces the tissue a little bit. So you can actually see into the pocket. And sometimes you can see calculus before you even have to explore for it, which is pretty cool.
Yeah, exactly. It's very cool. And so you might hear that we have yet to pick up a scaler. Like we've done, we're on like step 6 and we're just now talking about getting after the hard deposit with the PAs on. And then we can pick up our, check our tools to check. We can check, use our Explorer, Pigtail, whatever you're using to assess for calculus if you missed anything. I always like to go back on those lower anteriors, just in the contact points. I don't know why premolars. I think I missed that too much in school, so now I'm a little bit of a crazy person about going back in the premolars and checking. But I rarely do have to pick up a scaler, and what's great about that and what has changed is that first off, our scalers have been meant for hard deposit, right? Like unless I missed something, they were always meant for hard deposit. But we were asking it to just kind of smear around any of the biofilm for a really long time. So by removing all of this stuff and getting after the hard deposit, it's almost like it's very little collateral damage once I get to the scaler. I'm not removing cementum. I'm not removing any of the hard tooth structure, because I've done all this stuff and I'm just going after what's left, the little bit that I might find.
It's true. I would also say before you pick up a scaler, when you're using the Piezon, there's some smart technology built into the Piezon. So depending on how much lateral pressure you apply to the tooth, the Piezon will actually self-adjust based on the tenacity of the calculus you're trying to remove. So it definitely behooves you to use your Piezon before you jump in with your hand instruments. Now, when you talk about hand instrumentation, I like to say my office is a safe place for dental hygienists, and they can do what makes them the most comfortable. But technically speaking, theoretically speaking, you do not have to pick up a scaler. So if that's your comfort zone and you just love it and you have to pick it up, go ahead. But think about what's just taken place. You do not need to pick up a scaler. Think about the ergonomic benefit to us as healthcare providers when the last thing that you're now doing is picking up a scaler and, just sort of feeling around, or, you're not killing yourself like you maybe had done in the past.
Right. Yeah, like the last thing you're picking up is the one thing that's probably been causing you the most hand and wrist, shoulder, elbow pain.
Exactly.
And the patient is going to enjoy that, to be quite frank. There's quite a few of them that do not enjoy being scaled. You do have those occasional ones that like to, be abused for some reason. My mother being one of them. She's like, "Are you sure you got the back side of that one tooth?" I'm like, Mom, don't make me pass you off to another hygienist now. I don't need that back talk. I know what I'm doing. But there's some that just really want you to kind of get in there. And so you have to kind of retrain them a little bit. But man, most of them are super happy with this process.
Absolutely. And so I also think that it's pretty amazing when you go steps 4, 5, 6, airflow, PerioFlow, Piezon, how efficient this can be done. And it's quite incredible.
Yeah. And I mean, and what you're also doing, because you're doing the motivation, is you're making the next appointment easier and easier and easier. And now granted, I know this isn't magic. People aren't going to start doing all the things they should be doing the moment they step out. But these are the baby steps into we're looking to see what kind of plaque and biofilm that we have. We're talking nutrition. We're finding the aids that they want and need to use. And we are doing all of that at the front of the appointment. And the more we do that, the more we front load that, the easier 4, 5, 6, and I'd say even 7 get in this. And then what are we doing? We're truly preventing disease. Oh my gosh, hallelujah. The bells are going to ring and an angel's going to get its wing every time we do this.
It's so true. It's so funny that I can't help it. I'm a little cheesy anyway, but every time I hear welcome to Florida Probe. I just sit back and I just think an educational moment's about to take place. And my heart just warms for a minute. And then I go on with my day. But I just know that that's the beginning of the GBT appointment, and the patient is going to have an experience that's just worlds different from what they've had in the past. And they're going to be cared for better than they have in the past. And they're going to be engaged in their own health better than they had in the past. So here we are. We've made it pretty much through the whole therapeutic part of the appointment. Now, towards the end of the appointment, that's when I'm coming in for my periodic exam. And that's when we're having a conversation about restorations, cracked teeth, cavities, etc. All of the perio stuff has been handled. That's dealt with. So we're not trying to engage them on scaling and root planing and a water pick and all of this other stuff at the end of the appointment. All of the perio has been done. That's been established. We're moving on from that. The end of the appointment is for me to agree with my hygienist's assessment and recommendations. Obviously, if there's a modification to that recommendation, I reserve the right to do so, but I pretty much never have to do that. And I'm making my restorative recommendations, and that is when the patient is most engaged in their restorative process. So intraoral camera photos are taken. Patients, so when I walk in the room and I see a big cracked tooth in there, I know that conversation's been had. And the patient says, what are we going to do about this tooth? And they're engaged in that part. So we don't have to reinvent the wheel and re-educate them on all of the things that took place for the past 40 minutes. Now it's time to make restorative recommendations. I do my own oral cancer screening. The patient has their treatment plan for perio, and now they're going to have their restorative treatment plan. In my opinion, the patient has never been cared for better.
I'm so glad that you brought up the intraoral camera at the front of the appointment, or even in your appointment. And I'm using it quite a lot in the front of the appointment for multiple reasons. One being that I like to think I take great notes, like I'm such a great storyteller. But I mean, a picture is going to speak 1,000 words, and a video will speak like 1,000,000 words. So I'll sometimes even take a video of the after I disclose the patient, so that I can actually remember when they come back, when that stoic patient's in my chair is like, I hope I don't see any of that purple stuff again. I'm going to go back and look at those intraoral images and be like, yes, because we were really concerned about this area, and this is what it looked last time, and here's what it's going to look like today, so I can compare. I've had some sweet, well-meaning dentists that have come and done a check, like, everything looks great, see you in 6 months. I'm like, hold up. Let me just show you where we started here. So the documentation of it with the intraoral camera is it's such a critical part of that motivational step, I think.
I completely agree. And I would say that I know Amber and Sarah use the camera throughout the appointment. However, the restorative conversation is held until the end. So we don't go out of order. So basically, if you're going to take, say there's supragingival calculus, or you're going to take an image with disclosing, that stuff is all discussed. If it's perio, it's step 3. That's when it's being discussed, and that's when the patient's being educated. But when it's time to have the restorative conversation, we've got Carrie's technology and all of that stuff. Any measurements from Carrie's technology, any x-rays, anything that's going to be pertinent to the restorative conversation is held for the end of the appointment. We're not going to confuse them. The beginning's perio, then they get to chill and relax, and they get their non-surgical periodontal therapy. And then we come in and kind of reinforce the recommendations, and then I'll make restorative suggestions, and the patient's on their way.
That sounds like a good flow. Good flow.
It's a great flow. Why haven't we been doing this our whole career?
I mean, it took EMS to knock us all over the head. No, and I will say that I was using my sodium bicarb at the beginning of all of my appointments. I've always been a assess, probe, polish, Cavitron at the time, my magnetostrictive, because then I washed away the sodium bicarb taste, and then I scaled. But then I left all the conversation, the big important part of the appointment, to the very end when they were exhausted and done and frustrated. And, none of that was comfortable. I wasn't doing anything that was super comfortable, and I was in perio. So like I had to get in there with what I had, and they were fried. I was fried by the end of it. And like, gosh, this is just, it's a paradigm shift. It's a complete paradigm shift, and it's been needed. It's so needed.
It's so needed, and it's so amazing how impactful just tweaking the order in which you're doing things is for your practice. So obviously, yeah, I mean, I can't say enough about the AIRFLOW Prophylaxis Master. I love it. As a patient, I love it. As a provider, I think it's awesome. However, if you don't have it, don't feel like GBT goes out the window. You can actually take these steps and these practices and implement them into your practice with the tools that you have. Doesn't mean, you have to wait until you have the AIRFLOW in your hands. Doesn't have to necessarily be that way. I hope for you that you will be able to get your hands on an AIRFLOW Prophylaxis Master, because my gosh, your body will thank you. Mm-hmm. Your time management will thank you. And your patients will thank you.
So true. And, we're really kind of closing up this conversation, and we didn't even touch on dental implants and how great AIRFLOW is and erythritol is for the management of dental implants. And I know this is going to be a bold statement, but I think if you are managing dental implants, this is a must.
I have to agree with you. There is so if you have the opportunity to listen to Susan Wingrove, I'm sure she's been on your podcast plenty of times as well. Listen to her and some of the research that she's found out and she's uncovered about dental implants. I know she has a book coming out as well, and she's going to touch upon these subjects. But, you think, okay, once osseointegration's taken place, like life's good, we could just sort of treat an implant like a tooth. And obviously, there's the probe or not to probe, and, people have different points of view from probing. However, there's a whole chemotherapeutic approach to implant surfaces that we have to be extremely cautious of as dental professionals. If the oral environment is acidic, coupled with, high concentrations of fluoride, that can actually help to promote corrosion of the titanium surface of the implant. And if you took a little sliver of tissue on a patient that has peri-implantitis, you'll actually find little shards of implant surface that is made its way into that inflamed tissue. And so we have to be really careful with our product recommendations and also how we are managing our implant surfaces. And again, it's a home run with erythritol powder.
Yeah, and there is actually, it's a little older. I'd say it's probably 2017 this came out, but it was a systematic review on different instruments and different therapies for implants. If anybody's interested, I have it saved on my computer, but I can't for the life of me think of the author. But I definitely watched her at Europerio, and I fangirled like crazy. But she went through all the different ones, and what she really kind of went down to was that this is the one thing that's not creating any kind of change to the surface of that implant. And each implant company has like the secret sauce on the outside of it. And so it's not interfering with any of the acid etch and different things that have happened to the outside of these implants. And like you said, we can see some of that titanium and flakes of it in that inflamed tissue. And when we use that PerioFlow and we go subgingival in an area that has, hopefully we're catching it at mucositis, we can actually kind of disrupt all of that biofilm on both sides and really clean out everything and allow the body to start to heal. And dental implants they were my little baby course for a really long time, but I that's why I'm very bold about the fact that I think if you are managing implants in any way, in any capacity, and you don't have an AIRFLOW Prophylaxis Master, it's, I'm going to say subpar care, maybe. I know that's bold, but we're dealing with medical devices. We should have the equipment to maintain it.
I agree. And I also find that more and more, it's becoming more and more commonplace to create pretty sophisticated restorations. So all on fours, full arch cases. It's not something that just prosthodontists are doing. And sometimes, obviously we try to make them cleansable, but sometimes there are some that are more cleansable than others. And, we have to be able to get in there and take care of those implant surfaces, those prostheses, and ultimately that patient. So I agree with you. I think, where has the airflow been my whole life? That's basically that, and VoiceWorks. I feel like it's been,
Right.
and Sarah and Amber, but
Yeah,
all those things.
your amazing team.
It's really, and maybe Michelle someday. Basically,
I'm getting my Massachusetts license just so I can, on the off chance, be in Boston area and go and work in your practice.
I didn't hear off chance. You heard it here. Michelle is going
It's
to
coming.
be the next hygienist at Salem Dental Arts, and I can't freaking wait.
Oh my God. I would nerd out with y'all for an hour. I can't even imagine. I would just live there. Just give me a cot.
Yeah, we just wouldn't go home.
Put a cot in your cute sterilization area. Well, I just want to say, if anyone has any questions, you can definitely reach out to either one of us. We're also putting in the show notes the ems-dental.com, where you can take actual courses and learn more information. You can also get it here in the U.S. If you are interested, we'll be able to get some contact information for you so that you can, get a demo or whatever it is that your office needs, or at least chat to somebody. And Dr. Pam, where can they reach you or find you if they have any questions and want to listen to your amazing courses that you are always giving?
Thank you. Well, I would be delighted to chat with any of you at any point, especially if you're in the Massachusetts area and you're looking for your unicorn office. Joking. But you could contact me on Instagram at Dr. Pamela_Maragliano. You can email me at pmuniz, Muniz, at Endeavor, ENDEAVOR, B2B.com. So letter B, number 2, letter B.com. And hit me up. I'm happy to have this conversation with you. I cannot more genuinely explain to you how impactful this has been for my practice.
Yeah, and I hopefully you hear how genuine we both are in our love for this and how it has changed how we treat and approach patients with their disease management. So thank you so much for coming on.
Anytime. I'm always down for a conversation with you or Andrew, or both of you.